Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare.
Welcome to all of you. I'm Xavier Monnet. I'm an intensivist in Paris, and I'm very happy to welcome you to this webinar, POCUS webinar organized by the World Institute of Critical Care and Emergency Medicine. It's my great honor to moderate this first session. We will have great talks given by great experts, and without waiting, I introduce the first one, who is the father of this webinar, Dr. Ashraf Al Tayar, who is, as you know, an intensivist in Egypt, who will give the first 20-minute talk, and we will have the questions at the end of all talks, right, Ashraf?
Right, yeah.
So the mic is yours.
At the end of the 3 talks, yeah.
Very good. And so prepare your questions. You can also ask questions in the chat, and we will have all the questions summarized in the end. So please go on, Ashraf. We listen to you.
Hi, everyone in different regions of the world, and welcome to this webinar, which we aim in this webinar to try to convince those who are not yet convinced of the importance of the point-of-care ultrasound in ICU setting. And you're going to hear why it's important also in the emergency, let's say in every acute care setting that you may face in ICU, OR, ER, medical ward, surgical ward, anywhere where you have a critically ill patients or acutely ill patients. As we know that the critical care or point of care ultrasound in general, which is designed that you do focused goal-directed exam to answer certain questions in the very shortest possible time. And the impact of the presence of echocardiography in the management tools that you use in critically ill patients everywhere was found to be associated with better outcome. A lot of evidence on this. And that's why several years back, we started to hear people, expert people, publishing guidelines or consensus. They use term or word should when they identify the importance of point of care in hemodynamically unstable patients, that the critical care echocardiography has to be or should be done in every shock patient. And that's why every society, the American societies, Canadian, European Society of Intensive Care Medicine also, we wrote recently the consensus of the head to toe basic skills of point of care ultrasound for every intensivist. And we highlighted the importance of this basic skills that everyone working in ICU, and let's say also ER or everywhere, has to know this basic knowledge. And it's not luxurious at all. No, it's a mandatory to have this knowledge. And let me show you from the real life of in ICU how the point of care ultrasound made a lot of change in the management. As I said, I'm going to try to convince you that when we used point of care ultrasound, the management plan was totally different than the usual pathway of management if you use managing patients without using the point of care ultrasound. This is a lady who presented to our hospital with history of chronic cholecystitis and presented this time with severe abdominal pain, mild fever, right upper quadrant tenderness, vomiting, and then she was assessed in ER by bedside ultrasound by radiologist, and they found acute on top of chronic signs of cholecystitis. There was high CRP and white blood cell count. The surgeon decided to admit this patient to the floor, preparing to take her to OR once she is stabilized for OR. Unfortunately or fortunately, this lady started to deteriorate in ER. She became more tachypneic, tachycardic, started to desaturate, and the blood pressure dropped significantly to 90 to almost over 50 millimeter of mercury. And the lactate, when was checked, patient looked shocked. The lactate was checked and was found to be 6. With this white cell count and high CRP, history of cholecystitis, tender in the right upper quadrant, everyone was pointing toward septic shock to be the reason for this shock presentation with high lactate. And the logic thinking is that this septic shock is due to an infection inside the abdomen. So everyone is focusing on the abdomen to try to explain why this patient is shocked. And everyone was pushing to take this patient to OR actually, to try to manipulate and control the source of infection. Actually, when we were consulted, we do assessment, full assessment using the point of care ultrasound. This is our X-ray showing infiltrates bibasally, but doesn't show any significance more than this. When we put the probe as part of shock differentiation and management, we use the point of care and we put the probe in the subcostal area firstly. And then you can see here in the middle, this is the subcostal view of echocardiography. This is the right ventricle, left ventricle. You can see the pericardium and then a lot of fluid around the pericardium. And in this short-acting parasternal short-axis view, you see this is the left ventricle, right ventricle, and then you see fluid outside the right ventricle encircling in this apical 4-chamber view, encircling the whole heart. And you can see also that this is the IVC plethoric. So we see the right ventricle with a fluid around it or anterior to it, collapsing or causing collapse of the RV with this shock. This patient has a significant pericardial effusion with shock. So this patient is having tamponade. So, and there are a lot of things that we can do to confirm the tamponade. One of these is to fire the M mode over the right ventricle in the short axis, as you see here, and you can see the dipping of the right ventricle wall during the diastole, indicating that the right ventricle, because of the fluid out of it, is collapsing or pushing the right ventricle, not allowing the right ventricle to fill. So instead of going toward the septic shock, now everyone is thinking of pericardial tamponade, and this has to be drained immediately. Otherwise, If the time moves and this patient goes to OR without identifying the real reason for this patient to be in the hospital and to be shocked, can be catastrophic. This is the effusion again. What we do is not only to diagnose patients with tamponade, but also we use the ultrasound, point of care ultrasound, to guide tapping and pericardiocentesis. As you see here, the shadow of the needle going, we did this, the ICU team, we did this. This is the needle going into the fluid, and we aspirate this fluid, and it came like this, a hemorrhagic pericardial effusion, and actually the analysis of this came to be malignant pericardial effusion. Tell me, without echo, how can you reach this diagnosis and intervene to this patient to save her life? You can see here the time difference between 9:09 in the evening and the 9:13 the same night, when it was only 5 minutes for this pericardial effusion to be drained totally. And the pressure here, very low with very high dose of norepinephrine, 70 mic, reduced to 40 mic and pressure is better, reduced to 10 mics and pressure is more better, reduced to 0 mic of norepinephrine, and the right ventricle, as you see here, is nicely open, nicely filled. There is no sign of tamponade anymore. Another case which is commonly encountered in ICU, which is pleural effusion. Pleural effusion in ICU is very common. Around 60% of our patients, either they present with pleural effusion or they can develop pleural effusion later on. Not only that, but also the pleural effusion is one of the hindrance for proper weaning or actual successful weaning from mechanical ventilation. As you see here, this is the left side, which was shown on the X-ray before. This is the spleen, this is the diaphragm, and a lot of fluid, hypoechoic shadowing above the diaphragm in the region of the lung, because the patient head is here. So this is pleural effusion straight away. We measure the size of this pleural effusion, and once it's perpendicularly measured to be above 5 centimeters, you know roughly that you are dealing with significant pleural effusion. This patient was difficult to wean. And then we tapped this patient bedside without need for any intervention, radiologist or anything. Easy. When you use the point of care ultrasound, you direct your catheter inside the pool of the pleural effusion without touching the lung, which is sitting here, or without injuring the diaphragm, or even going to the spleen or liver if you're on the right side. Big tail was inserted, guided by ultrasound, and 3 liters of fluid was removed. The patient was not yet improved. The X-ray was showing still presence of effusion, and the patient is still unable to be weaned from mechanical ventilation. What could be the problem? If the catheter is sitting there, what could be the problem? Ultrasound can help you to reach why this effusion is not fully drained. You can see here, this is the spleen, this is, part of the heart, and this is the pericardium, this is the pleura, and this is the lung here, and here you can see a mesh of pleural effusion with a lot of debris and fibrin threads inside the pleural effusion. Very complicated pool of significant amount of effusion. If we zoom in using the vascular probe, you can see this is the spleen, this is the diaphragm, and the effusion with a lot of adhesions inside, preventing the catheter to drain this fluid. And here you have to decide with thoracic surgeon what to do next. Next is either you go to OR to drain this significant amount of effusion remaining, which is the main reason for this patients not to be weaned from mechanical ventilator. And not only that, the debris you've seen and the adhesions you notice inside the pleural effusion is anchoring the diaphragm. I'm going to show it to you again. If you can see here, you see this is the diaphragm, and this is the adhesions anchoring or attaching to the diaphragm and preventing the diaphragm from smooth movement. This is most likely, plus the diaphragmatic effect, plus the significant amount of effusion that is pushing and collapsing the lung are the reason for the failure to wean. We decided with thoracic surgeon upon discussion to go with adhesolysis using the RTPA. Thrombolysis, this is the catheter you can see here. And we inject, as you can see here, the thrombolysis, and then after we could remove around another 3 liters of pleural effusion, but the patient is still not improving. What could be the reason? There are 2 reasons for the lung to deteriorate after pleural effusion tabbing. Either your patient develop re-expansion pulmonary edema, unlikely if you drain the fluid over long time. Another reason for difficult to wean after pleural fluid tabbing is probability of pneumothorax. This is the left side where we drained, we inserted the catheter. You can see the pleura sliding and you can see B lines. And this is the M mode showing sandy area, no barcode. So 3 signs of no pneumothorax when we put the probe on the second, the intercostal space, a mid-clavicular line. But when we moved the probe down around the area of insertion of the pigtail, we can see here clearly that this pleura doesn't move, doesn't slide, and there are a lot of A lines here. This is one, and this is another one. But you can see part of the pleura from the above space is sliding slightly. Meeting of a sliding with no sliding, we call this is the lung point. And if you put the probe over the non-sliding pleura, you can see barcode as you see here. Again, another loop here. This is the spleen. This is the diaphragm. This is a small remnant of pleural effusion. The pleura near to this area is totally non-sliding, showing a lot of A lines, indicating that this patient developed pneumothorax. To prove this, we did the CT. You can see here the air on the CT. So CT is a gold standard for investigation of the lung pathology in critically ill or non-critically ill patients. But the lung ultrasound is not inferior to CT in diagnosing pneumothorax, in diagnosing pleural effusion, particularly if you are talking about bedside test, portable, available machine, available 24/7. What is lacking here is people in ICU capable of dealing with this machine, knowing how to work with this machine, how to use it, or how to interpret the finding that you see on this portable bedside facilities. Here, the lung ultrasound could diagnose the pneumothorax post-pleural tabbing. What we did is aspirating the air through the pigtail, and as you see here, that the lung started to re-expand again, the pleura started to slide again, and we started to see B lines again. If you see sliding pleura with B lines, which are the vertical lines that move with the pleura and end by the bottom of the screen, are signs totally against the presence of pneumothorax. And this is the follow-up, CT follow-up X-ray. You can see the difference. There is no air after you did the intervention needed. One of the common scenarios that we are facing every day in ICU is like this patient post-cardiac arrest, intubated, but remained after the CPR, remained desaturating and not well. And the air entry was not heard very well on the left side, very diminished, though the endotracheal tube was pulled out by the ICU team till they reached 20 centimeter. And as you can see here, the left side is totally collapsed, white lung, while the endotracheal tube is up high above the carina. So what could be the reason for this? When we did the lung ultrasound exam on the right side, you can see the pleura very nicely sliding, and you see some A line and false B lines. But look at the left side. This is the left side mid-clavicular line. This is Arab shadow. And this is the area where you have to see the pleura and you see it sliding or not sliding. We don't see at all the pleura, but what we can see here in the bottom left, that the lung is as if it's pulsating or beating with the heart. Lung pulsation is a sign on the lung ultrasound that indicates no air. Means that if you are seeing the lung pulsating, it indicates that you don't have pneumothorax for sure. One. Two, another possibility or differential diagnosis for lung pulsation is that this lung has no air. There's no air reaching this lung. What could be the reason for this? If you already taken the tube out, confirming that the tube is sitting above the carina, so the air has to go to both sides. What prevents the air from going to the left side is that probably there is intrabronchial lesion or obstruction that lead to collapse of this total collapse of the left side. As you see here, you see a sponge-like or hepatinized lung. It's almost like a liver, but this is on the left side. This is the spleen, this is the diaphragm, this is total collapse. And if you see white dots inside the lung tissue here that does not go on and off with inspiration and expiration, we call it a static air bronchogram. This indicates that you are dealing with total collapse. Again, this is part of the heart, and what you can see here is total collapse of the lung. This is the spleen, this is the diaphragm, this is a rim of effusion, and lung is hepatinized or tissue-like. Then this is total collapse. Bronchoscopy done, and this and CBT, and this is the repeat of the study. This is the left side. Before the bronchoscopy, you see pulsation, no pleura at all. Here you can see the pleura nicely, and you can see some of the false B line and E line. And here we are near to the heart, where you can see still the pleura. So the pleura came back, and the sliding came back, indicating that after bronchoscopy, the aeration of the left side was better. And here you can see more evidence that the lung is fully recovered, fully aerated now, sliding, nicely looking pleura with B lines. This is the spleen. This is another zone, zone 2 and zone 3. You can see evidence that the dots, white dots, is becoming now dynamic, indicating it goes on and off with inspiration, indicating dynamic air bronchogram, which is a sign of consolidation. And this is how you differentiate between consolidation and collapse. Ladies and gentlemen, we are not here to tell you everything, but we are here tonight to convince you that using point of care bedside is gonna let you reach the diagnosis very easily in a shortest time, and then you tailor the management plan according to this. One of the common problems in ICU that necessitate a call to the intensivist every now and then, even in the middle of the night, that your patient started to be oliguric. Very common, up to 50% of our patients. One of the common indications to give fluid empirically is that patient develop oliguria. Ultrasound has to be applied before you decide anything for oliguria. You have to look for the urinary bladder first. If you see the bladder full like what you see here, you can see also the catheter, if it's blocked or not. You can tap this fluid, aspirate, and you see if the urinary bladder is decreasing in size or not. You can see if the kidney is back pressured with hydronephrosis, if you are dealing with obstruction or not. You can do a lot of things using the ultrasound. You can diagnose even tumors inside the urinary bladder, stone inside the urinary bladder. If you don't see, or you see the urinary bladder as a slit, and you want to confirm that this is the urinary bladder, you can flush the bladder and see this is the saline pushed inside the urinary bladder to confirm that the bladder is not a problem. Then you go with the scheme of should I give fluid or not? continuing doing the point of care ultrasound to reach the diagnosis, and you give the fluid or don't give the fluid. We have a lot of things for you to learn in this fellowship program, which we are preparing for. We are preparing for this fellowship program to be at your hands with a lot of experts from all over the world. We worked with them in different regions of the Gulf, in Middle East, in Europe, and we know them. We know their caliber in teaching. We bring them for you then, and we applied this science since several years. We know we have a group of experts who know what to teach and how to teach. What is next is that you join us for this webinar, for this coming fellowship, and we promise that you're going to find everything you are looking for to be safe in practicing inside the ICU. With a lot of these names are in this fellowship program. Hopefully, we start next June, maybe 30 of June, and Dr. Walid Alhabashy will highlight a lot around the program of this fellowship. Thank you very much, and I'm ready to take your questions.
Thank you. Thank you, Dr. Ashraf. Let me thank our program director, Dr. Ashraf Al Tayar, actually for this fantastic talk. Actually, he showed us how the point of care ultrasound changed our mind. You are thinking about a patient of septic shock and suddenly you find another diagnosis. So thank you, Dr. Ashraf. And let me introduce myself. I am Dr. Haytham Khalifa. I am an emergency consultant. I am the second moderator in this webinar. Actually, I am the Suno School manager, and it's my pleasure to be in this fellowship under the umbrella of WICCEM in collaboration with Save Life Academy. Let's introduce our second speaker, Dr. Wesam Ibrahim. He is MD, PhD, Emergency POCUS and Trauma Fellowship, visiting Associate Professor at the University of Colorado, USA. He is the Scientific Co-Chair of Suno School International, and actually he is International Instructor in Resuscitation courses, Trauma courses, and the founder of REBOA course in the MENA region, and he is active member in different societies like ASEP and IFEM. So let's introduce now Dr. Wesam, and please, if there is any questions for Dr. Ashraf, please write in down in Q question and answer down in the toolbar. Okay, let's start with Dr. Wesam now.
Hi everybody. Our lecture today is point of care ultrasound in acute care settings. Do we really need it, especially in emergency medicine? This is Wesam Ibrahim. A small hint and background on sound wave. Sound wave is a series of pressure waves propagating through a medium. Our normal sound range is from 20 Hz up to 20,000 Hz. The idea of ultrasound is beyond this 20,000 Hz, with two types of working. The ideal and regular and the old one was the piezoelectrical crystal found under the probe covered by a ceramic plate. This piezoelectrical crystal has a dual action. It's emit the ultrasound, which hit or strike an object, then reflected to the piezoelectrical crystals again to be interpreted as an image on a screen. With the new revolution, with this engineering, technical engineering and manufacturing of the devices, a new idea about using the microchips make the device smaller and make the probe of multitask, maybe 2-in-1 or 3-in-1, and this is the idea of Butterfly IQ invention and other competitors in the market. Now we implement to the idea of ultrasound is the stethoscope of the future. But why we should use POCUS? An important paper was published in 2018 in JAMA Journal, one of the prestigious Q1 journal. All what we learned during our medical school life is that the diagnosis in medicine depend on inspection, palpation, percussion, and auscultation. Now we add a fifth pillar, which is insonation. Let's play the game in a different way. The first important use of the point-of-care ultrasound is diagnosis. You are a decision-maker physician. Let's take our clinical scenario and judge at the end. Case 1. A male patient 60 years old with a difficulty in breathing, decreased urine output over the previous 2 days, with vital sign shows tachycardia of pulse rate 130, with respiratory cycle 3 cycles per minute, and the oxygen saturation 95% on room air. With clinical examination with the usual stethoscope, we found bilateral equal air entry and no added sound was heard. Investigation shows creatinine is 5 milligram per deciliter. So our game challenging now is the case is shock, pre-renal or renal cause or post-renal cause. Let's play with our point-of-care ultrasound. Now we do here lung ultrasound shows normal lung sliding. Do echocardiography and parasternal lung view shows rapid repetitive leaflet almost hitting the septum, indicate hyperdynamic circulation. Looks to our kidney, it shows a normal kidney with a normal echogenicity in the middle, which represents the hilum. Here, looking to the IVC shows collapsed IVC. IVC is empty here. So it is one type of shock. What is this type? Is it a pre-renal, renal, or post-renal cause? Let's emphasize what we see: normal lung, hyperdynamic ventricle, normal kidney, and collapsed IVC. The cause, of course, it is a pre-renal due to a hypovolemia. So what is the solution? Give him plenty of fluid. The second case is almost the same. Patient, 60 years old male, difficult in breathing, decreased urine output over the previous 2 days with tachycardia and the oxygen saturation 95% over room air. On examination, although the air entry is bilateral and equal, but we have added sound which is a crepitation. Investigation shows creatinine 5 milligram per deciliter. Let's play it again with our POCUS. Here we did the lung ultrasound, shows multiple P line, more than 2 P line, indicated a congestion in the lung. Here, doing our echocardiography in the parasternal lung view shows a very lazy leaflet. It's not almost reach middle the way between the septum and the leaflet, indicated left ventricular dysfunction. Here, have a quick look on the kidney. It shows our beautiful normal kidney with normal echogenicity in the middle, indicate normal kidney, of course. And here, have a look on our IVC, which shows a plethoric IVC. This is like some sort of congestion. So what is the cause? Say it again. It's a pre-renal cause, renal or post-renal. Emphasize our POCUS, by the same. He's like a wet congested lung, left ventricular dysfunction, normal kidney, and plethoric IVC. Yes, totally right. It is a pre-renal cause due to heart failure and generalized congestion. In this case, don't give fluid. It is harmful to give a fluid. Just inotropes and get out of this volume overload. Get rid of it by dialysis. Now, our third case, the same case. 60 years old male, difficult in breathing, decreased urine output over the 2 days. Vital sign shows tachycardia with slight hypoxia. Saturation reached now 88% on room air. On clinical examination, we show bilateral equal air entry, but we still have the add sound with accreditation. Investigation shows the same with creatinine 5 milligram per deciliter. So, do ultrasound now. We have the lung with P line, multiple P line, indicated lung congestion, although the sliding is normal. Here, our heart shows that like the leaflet is lazy. It is not reaching the septum. There is a problem here in the heart in parasternal lung view. It indicates left ventricular dysfunction. So it is something acute here. Although our kidney there is loss of differentiation between beautiful cortex and the inside medulla. You can't differentiate. There is no differentiated between the outer cortex and the inner medulla. There is something growing inside the kidney. Let's play it again. The cause pre-renal, renal, or post-renal. Let's now emphasize our finding: wet lung, left ventricular dysfunction, and corticomedullary undifferentiation. Our case is a renal cause. It is acute on top of chronic renal failure. Our fourth case, the same case, male patient, 6 years old, difficult in breathing, decreased urine output over the previous 2 days, pain from loin referred to groin. Vital, it's still tachycardia with heart rate over 130, oxygen saturation 88% in room air. On clinical examination, I found bilateral equal air entry by stethoscope. Investigation shows creatinine 5 milligram per deciliter. Looks to our beautiful POCUS. Our right kidney shows normal beautiful kidney with whitish from inside, whitish echogenicity indicate normal hilum. On the left side, I see here moderate hydronephrosis, moderate up to severe hydronephrosis with this empty pockets. So there is something in the left kidney. It is a hydronephrosis. Look to our bladder, urinary bladder. There is nothing abnormal. It is a normal urinary bladder. So normal right kidney, hydronephrosis in left kidney, normal bladder. Let's look about our cause. Is it a renal, pre-renal, or post-renal? Of course, it's a post-renal with obstruction, and this time it is unilateral obstruction, maybe by stone or whatever. Our last case, now it is a newborn with respiratory distress, no urine output at all. Vital sign, heart rate 199 with respiratory rate 50 circle per minute. Oxygen saturation is 95% at the room air. On examination, bilateral air entry are normal. Abdomen is distended. Serum creatinine is 5 milligram per deciliter. Let's do our POCUS. Our right kidney here is huge, enlarged with huge hydronephrosis. So this is severe hydronephrosis on right kidney. Our left kidney shows moderate up to severe hydronephrosis. So notice the obstruction may be bilateral or in the median level. This bladder is like hugely distended bladder, as you see. So is it renal, pre-renal, or post-renal cause? Emphasize our finding: right kidney hydronephrosis, left kidney hydronephrosis, distended huge bladder. It is a post-renal cause, and this time it is bilateral hydronephrosis, maybe posterior urethral valve, something congenital or whatever, bilateral obstruction. This is like paved the way for more and more advantage for point-of-care ultrasound. With point-of-care ultrasound, we can resuscitate critically ill patient, many protocols. We choose one of them, which is rush protocol. Rush gives the sensation of fast, rapid. You have to do something to save the life. Yes, and it is abbreviation of rapid ultrasound for shock and hypotension. We use the mnemonic HIMAP to search for the finding. We find here fast, doing right upper quadrant, left upper quadrant, right and left, doing suprapubic, and so the bladder and subpubic. You look the subcostal and see the heart from this angle. You can do the pleural effusion as a spine sign through the right upper quadrant or left upper quadrant section. Look to the lung. Is it a normal, beautiful sliding, or you have something called lung point, indicated maybe like a pneumothorax? Look to the aorta and the horseshoe sign made by the shadow from vertebra, and look if there is any problem with the aorta. Is it a dissection? Is it aneurysm, or there is a flap? Look to your IVC. Is it normal, collapse, or plethoric? Look to your beautiful heart windows. Look to apical fourth chamber. Look for parasternal lung. Look for subcostal view, which we discussed before with fast. Look for parasternal short view and see the valve. Our cardiology ultrasound is not a regular like the cardiologist. It is a point of care, question and answer. A very important paper was published in the Academic Emergency Journal by a crew from Yale University, indicates the use of 5 E's: equality, effusion, entrance, ejection fraction, and exit. The third usage for our beautiful and smart point of care ultrasound for monitoring therapy. We can use the IVC size to judge also the lung. Is it empty or congested? Look for our happy well, indicated a good hydrated IVC, or look for our congested IVC, indicated by the bunny sign. Look for our beautiful lung sliding, or alveolar interstitial syndrome with multiple P line, indicated congestion or an infection or fibrosis. The fourth usage of ultrasound is the procedure guidance. We may do all our injection or insertion of line under ultrasound guided to avoid the medico-legal aspect if there is any problem. Now you can insert the central line either in plane technique or out of plane technique. We can use it to modify the regular and old era entrance for doing some maneuver like pericardiocentesis. Usually in the past we do it through the beer area in order to avoid lung injury. Now under ultrasound guided, you can do pericardiocentesis through apical fourth chamber view or subcostal view. Also ultrasound femoral nerve block. Also ultrasound guided lumbar puncture, many maneuver, incision, drainage of abscess, even thoracocentesis, paracentesis, or arthrocentesis. That our final No, we still have more. Just hit the button and you will expect more. Our ultrasound can be divided into multi-targeted examination, like using the protocol or just a single examination. Multi-target including cardiac arrest, or using the ultrasound in trauma or non-traumatic, or dyspnea and blue line, or chest pain, or using as individual. We can use our ultrasound here in a horizontal section to put and insert endotracheal tube with 100% confidence that we don't put a wrong insertion in esophagus. On a longitudinal view here, we can insert our cricothyroidotomy kits with safe and happy and very rapid. Here our ultrasound for eye. We can detect the vitreous hemorrhage. We can detect retinal detachment, either unilateral or bilateral retinal detachment, and differentiate between vitreous hemorrhage. Optic nerve measurement using for measurement of intracranial pressure, or even find any retrobulbar hematoma. You can use it as an obstetric module in ectopic and rupture ectopic pregnancy during childbearing period. You can use it as a bilateral biparietal diameter measurement for a fetus. Also, you can do it to measure the heart sound fetus in peak-to-peak or peak-to-peak measurement by M-mode. In a testicular torsion, you can use our beautiful power Doppler to detect is it the dangerous torsion with completely ischemia and urgent operation, or just normal, or just increased vascularity, indicate epididymoorchitis, which need antibiotic treatment. Also, game changing in doing DVT compression test. Although doing a test consume 1.5 hours to detect the whole point of DVT, just do compression test in couple of minutes. Now we can detect any finger abscess or a small object by using the era of augmentation under water. Also, we can detect the cellulitis and the beautiful cobblestone appearance in POCUS. You can find any fracture or joint dislocation in one view. In X-ray with less sensitivity, we need anteroposterior and lateral view. Here in ultrasound, just it is one view. Also, we can use it for neonatal cranial ultrasound through the anterior fontanelle, using ultrasound wave to detect any extradural hematoma in neonates. Now, we reach our take-home message. Always remember that training is continuous process, and the eye can't see what brain doesn't know. Dr. Walid will discuss in detail how we will assess your work in image to reach the highest quality in getting learning. Learning pyramid starts just with a lecture with advantage of 5%. By reading, by repetition, audio visual, demonstration, discussion, and asking, then you can teach the lecture to reach 90% of learning. But we will still learning till the end. Thank you so much. Thank you for attending this webinar. Waiting for your nice question at the end of the day. Thank you again.
Thank you very much. This was, again, a very nice presentation with a lot of examples how echo can be useful. And we move immediately to the third presentation, which will be given by Dr. Walid Alhabashy, who is a consultant in anesthesia and intensive care at Dorset County Hospital in the UK. He is a great specialist in ultrasound. He's the clinical lead for critical care ultrasound. He has supervised and created many courses about echocardiography, and he's the author of a book on critical care echocardiography. And so I'm very happy to introduce you, Walid. and even more to listen to you for this presentation.
Fantastic. Thanks very much for the nice introduction. And I hope we had, by this moment, developed some enthusiasm on emergency and critical care ultrasound. And some people now would like to adopt that for their clinical practice on day-to-day basis. And hereby, I would shed some light on a point-of-care ultrasound fellowship in acute care settings, a full 1 year or 48 online fellowship, 48-week online fellowship program. So in the coming 12 to 15 minutes, I would highlight the program overview, including but not limited to what we're going to cover, what are the target audience we are interested in, what are the program key features, what and who is doing what qualifications and who is doing that in our faculty, what are the learning styles and methodology we adopt. And after you finish this 1 year or 48-week training program, what are you expecting to get out in your hand after that journey? So this is a 48-week training program, online, virtual, divided into 2 main pathways. The first pathway is what we call, or we named it, the common pathway. So everyone is entitled to do this pathway as a beginning of the journey, the first 24 weeks, during which we will discuss the basics between every single ultrasound in medical education platforms. So we discuss physics, cardiac ultrasound, the basics, lung ultrasound, the basics, focused assessment with sonography for trauma patients, the basics, infused vena cava, DVT, shock management, all the basic standards for everyone, regardless you're an intensivist, a medical specialty or subspecialty, you're an emergency physician, and we will end up by 2 weeks of exam, which will entitle you to go either of the 2 specialized pathways. So the second half or the second module is a 24 weeks module, which will be either as emergency track or the critical care advanced track. If you're an emergency physician, you will pick the first one. If you are a critical care physician interested in advanced critical care ultrasound, this is you pick the second track. But either way, you will have to do the first common pathway. So in the emergency track, if you are interested in advanced emergency pediatric ultrasound, obstetrics and gynae, genitalia ultrasound, musculoskeletal, nerve blocks, you're interested to know more about emergency point of care ultrasound, different protocols, and other specialties related to that, please be welcome to that first emergency track. If you are interested in advanced transthoracic echo, focused transesophageal echo, regardless you pronounce that as American Canadian by TEE or the British Irish as transesophageal by TOE, so it doesn't make a difference. Welcome to join us in the critical care section. VICCEM score, different ECMO modality, extracorporeal membrane oxygenation, different modalities, fundamentals definitely, and advanced management with ultrasound guidance, plus other highly interested specialized areas in critical care. Again, welcome to join the section of critical care track as a second module. So you will do 2 of 3, depends on what you are interested in. One is the basic or the main pathway, or the first pathway, the common pathway, and then you will pick one of 2, emergency or critical care, depends on what's your specialty in medicine. Now, our key features. Every week has certain steps you will be achieving during that one. You have recorded lectures, which we adopt the flexible learning style with a 24/7 access to these recorded video lectures, allowing you to learn at your own pace and time. Then case studies that will be published every week. So this is all case-based scenarios. We'll adopt everything from the practical point of view. We're not discussing theory. Yes, we are discussing everything as per the current evidence and we will as well discuss in journal clubs, but all things that really matters from clinical perspectives. So we are interested in the clinical settings more than anything else. We're not discussing just theory for theory. So this is our mindset during this fellowship. And as well, every week, every 5th week of this program, you will have a live webinar. In this live webinar, it will be led by renowned international speakers, providing really highly interactive sessions with direct engagement with all questions. So this is what we think should be the way. Every week we'll have questions, and the questions will be just for your own learning. It's not to test you. It is not a mere question to test you. It is actually to show you how much did you learn out of this journey. We have a global faculty, so please, if you follow us or if you follow this fellowship program, you will learn from 30+ leading expert and distinguished panels from the United States, Europe, Canada, Middle East, Africa. So it's the cutting edge of internationally recognized program designed to equip the participant with the latest ultrasound techniques and best practice in emergency and critical care medicine. Here, I would like to invite you to explore our esteemed faculty. For more details, please visit WICCEM Point of Care in Acute Care Settings page. We can't be proud enough with our faculty and our team that we had been working together for years and years, and we know each other almost like a family. So, as I previously mentioned, our teaching methodology during this fellowship 1 year, our program is case-based discussions inherited into different lectures, evidence-based journal clubs, developing your critical appraisal, what sounds right, what sounds wrong, systematic meta-analyses, and reviews up to the benchmarking of the current evidence. As well as we will be inviting you to do the hands-on sessions in 30 logbook cases, just to show us that you had been implemented in hands-on practice. We invite you to attend the well-enumerated courses according to different societies and show us the certificate of attendance of any of these courses. We will assess for your learning as we are entitled to do that, and we're committed to do that. So each module will be assessed via MCQs with detailed explanations. This is just to foster the environment of learning rather than a mere testing. So we advanced virtual simulators, and this is a changing of a mindset now. It is not just about attending lectures and discussions online. No, we'll take that the extra mile. We'll do virtual teaching via special simulators, so you will get an immersive experience, and you will do a lot of learning via yourself. So you will put your hand on the probe here. So this is part of the simulators we will use in the advanced section of critical care. For instance, we are adopting this software via MST company, Mr. Timothy. So you will be pushing in the probe yourself. You will be pulling the probe outside yourself. You will rotate the angle yourself. You can put the color Doppler. You can put the pulse wave Doppler. So you will bring the views. So this is a mentored and supervised sessions to improve your exposure. So this takes your education and learning to a next level. I wish if we can also do that physically in our hospitals, but unfortunately, we cannot accommodate this high number of attendees of such fellowship to do that personally. But again, as your mentors and supervisors, we are very happy to bridge you to the faculties that can facilitate that one day. So again, this is just to improve your exposure in an online version of a software that can help you a lot to learn the transesophageal echo. And there will be a similar one from emergency department, like for things that is very difficult to do in real life. Like, for instance, you can do transthoracic echo on a volunteer, but you can't do that on transesophageal echo. Obs and gynae exams are the same from emergency department perspectives. That's why you will have simulators similar to that in obs and gynae in emergency section. The high-yield topics, definitely we are definitely covering all the cardiac lung procedure, highly specialized areas and special interest areas. So everything in the left ventricular, right ventricular assessment, pericardial effusions, valvular heart disease, all this mentioned about cardiacs and lung ultrasound mentioned by Dr. Ashraf Al Tayar today will be covered. Procedural like vascular access, nerve block, pericardiocentesis by the emergency team will be covered. Specialized areas, again, will be covered. So it's all under one tent. So the last question here. Okay, Walid, if we are now going to register for this program as soon as it is advertised, what we're going to get at the end of this one? By the end of this comprehensive 48-week fellowship, it's a full comprehensive year, that you are getting the certificate of fellowship. So you will be awarded the fellowship certificate upon successful completion of the fellowship, recognizing that you are now developing an experience in ultrasound in the term of theory and some hands-on. Plus, if you submit us the training program of any of the well-known courses across the world, you will be mastering the point of care ultrasound. So you will develop strong theoretical foundations, clinical understanding, practical proficiency in all ultrasound techniques, ensuring you're competent to manage that in real-world clinical practice. Again, you will have an access to our global professional network, and it's a great community of experts who have been dedicating their careers and to master and teach critical care and emergency ultrasound. This program is designed to empower all the interested clinicians with the cutting edge of recognized qualification in the field of ultrasound. We're still to do 3 more webinars, so please mark your agenda. 15th of April, 13th of May, 10th of June, we will meet again to highlight more areas that may not have been so clear in today's session. So it is just the first session, and more sessions are coming to explain more and answer more questions about the program. Everything from our side is crystal clear. We are definitely sure that you have a lot of questions. Your questions are legitimate and genuine, so please feel free to ask. The floor is yours. Back to the panelists. Thank you very much.
Thank you so much, Walid. It was a very clear presentation of this so nice teaching program. It's really very exciting. Thank you to the 3 of you for your nice presentations, and especially for the 2 first ones who gave some very attractive cases convincing people that you must know echo and that you must learn echo. Now we have 15 minutes for questions, and we will moderate these questions with Haytham.
Yes.
We have a question likely for you, Ashraf. How is POCUS effective typically in septic patients with vasoplegia? Can you give us some examples how it can be useful?
Yeah, thank you very much, Xavier, and thank you very much for this very nice question. I saw it in the Q&A. Actually, the good and excellent rule of point-of-care ultrasound, particularly critical care echo, in management of septic shock is that you know the phenotyping of the septic shock. What kind of hemodynamic presentation is there? Because not every septic shock is vasoplegic. When you see the heart hyperdynamic, you see it, you didn't hear about it. Because the question is usually valid between comparing echocardiography, bedside echocardiography, and the other alternative semi-invasive or invasive techniques to diagnose septic shock phenotype. And the real and great advantage of point-of-care ultrasound is that you see the anatomy and you see the physiology by your hand, by your eyes. You didn't hear about it. When I tell you that the systemic vascular resistance is this or that, is not like you see the heart very hyperdynamic and you see that this patient needs to give fluid and maybe to go early with the vasopressors. On the other hand, how can you diagnose septic cardiomyopathy without echocardiography? And by the way, as I showed in many other presentations, the septic cardiomyopathy is very common in septic shock. Patients present with hypodynamic heart, not hyperdynamic heart. Without echo, yes, you can see in the thermodilution technology that the cardiac output is diminished, and then you're gonna be very confused why I'm dealing with septic shock. By the way, so early in presentation, few hours of presentation with septic shock, even in young patients, even in those with no history of heart disease, they present with septic cardiomyopathy. And the only way, again, the best way, no, I'm not saying only way, but the best way to properly diagnose that my patient doesn't need at all fluid, but needs inotropic, and not better to avoid vasopressors, is to see with your eyes that the heart is not functioning as hyperdynamic heart. This is very, very crucial in my opinion.
Thank you, Dr. Ashraf. Actually, my question is to Dr. Nivisha Barag as a question of our candidates. Our faculty showed us what are the benefits, what the outcome of the using POCUS in acute care setting. So what about the limitation? Are there any limitation or pitfalls of POCUS in acute care setting? And how can we balance between clinical judgment and with the POCUS finding in acute setting?
It's for me or for
For Dr. Nivisha, if Dr. Nivisha with us. Okay, Dr. Nivisha. Okay, Dr. Ahmed.
Yes.
Yes.
Hello?
Yes, Dr. Nivisha, did you listen to my question?
Yes, please can you repeat that? Sorry, I was on mute.
Yes. Actually, our faculty showed us what about the outcomes and benefits of using the POCUS in acute care setting. So one of our candidates asking about the limitations, the pitfalls of the POCUS, and how can we correlate between the clinical judgment and the POCUS finding in our acute care setting?
Absolutely. Thank you so much for that question. And I think we can all concur. So I'm currently practicing in South Africa. It is quite a resource-based setting. So ultrasound use, when it's available, is an immense help to our patient care. So just with regards to addressing the question itself, the most important thing with POCUS is to ensure that it is a focused examination, trying to answer a binary question of some sort. So you have a patient, you are concerned about something. So for example, is my patient volume depleted or not? And then you use your ultrasound to answer a question simply by stating yes or no. POCUS is not a detailed examination such as a detailed echocardiography scan performed by a technician in that field, or any other scan performed by a radiologist in their expertise. So the pitfalls of using it in the acute care setting is when we don't use it in the appropriate context. And I think it's very important to keep stressing that point of care ultrasound is used as an adjunct or as an extension of the clinical examination, and not to be solely relied upon. So you have to tie in what you're finding and what question you're asking with the findings from your clinical examination. So I see POCUS as an extension of my clinical examination, and an exceptionally useful one when used in the right sequence and setting. Thank you.
Thank you so much for the answer. Walid, I think we have a very practical question, an administrative question. Are there, is it planned, I cannot find it again. Is it planned that it gives some credits, that the teaching session gives some CME credits? It was a question from Eman.
Thank you, Iman, for flagging that up. As I said, this is not the end of the journey. We have 3 more webinars. We will highlight a lot of things, but it's one of the cornerstones that nothing goes unaccredited. Everything you do will be accredited. So we have an EACCME accreditation. So European Accreditation Society, European American Accreditation Society, EACCME. This will be accredited via that one. But we are going beyond that step. So it's not just the CME that we are interested in. We'll be mentoring and supervising our colleagues who are attending this program, and will extend the network of communication to be via mentorship program, so we can help you to be finalizing this 1 year of fellowship, not just for theory. No, we are trying to help all who were involved in this fellowship to finalize a qualification plus this one. So if you're interested in European Diploma of Echo, or the American Society of Critical Care Echo, the National Board, something like that, you will have some hand-on logbook submission. So we are supporting you, because this is what our life mission is about. So we don't want to contract that to just the accreditation, but yes, I guarantee you an EACCME accreditation, if that's your question. Thanks, Iman.
Thanks. And we have a question from Emad, who asks, if I choose, for example, the emergency track, does it mean that I have to learn all the topics under it, or I have to choose one of the topics, for instance, MSK or pediatric?
Ashraf, would you like to answer that question, or you would leave it to me?
Yeah, it's very clear that when you finish the common pathway, you choose yourself to go to the next specialized track, which is either emergency track or critical care track. And you have to finish the whole module of emergency or critical care. Wesam, you want to comment on this, or Haytham?
Can I just reflect one piece of more knowledge to make it clear if it wasn't? We are going in modules. So if you finish module 1, you get the accreditation for module 1. If you finish 1 and 2, you get the 1-year fellowship training program certificate. So it is not as part of any module you will be accredited for.
Yes.
So this is the mindset. So it's three tracks, but you will finish 2 out of the 3. So if you're interested in Ops Gynae, for instance, you cannot do that as a solo module and ask for a certificate for that. That's not our mindset. We're trying to cover that in 24 weeks for general module, and then you have the right to get the certificate and leave, which we don't prefer, or continue with us either in the emergency section 24 weeks more, or the critical care, advanced critical care track 24 weeks more. But you have to finish 1 full modular training in one go to get certificate and accreditation for that. Correct me if I'm wrong.
Yes. Yes, thank you, Dr. Walid. Actually, wanted to add in the emergency module, actually, you don't need only to be an emergency physician, but actually all of physicians that work in the emergency department, this module will be beneficial to them as we face pediatric cases, as we face some patients with fractures, torsion, something like that. So this module is also for all doctors that work in emergency department. Let me
very
ask.
Important, Haytham, if you allow me. This is very important because we have people from outside critical care and emergency. Yeah, point of care is for everyone working with acute care settings.
Yes.
Primary care, the internal medicine, surgery, whoever is working with acute care can attend this fellowship and get benefit from. Thank you.
Yes, there is a question, Dr. Ashraf, that one of the candidates asked that you showed that will be like a virtual simulation and maybe electronic logbook and all theoretical and clinical cases. Would maybe a chance for some hands-on training with expert on site and something like that, maybe later on? Someone asking.
I prefer that Dr. Alhabashy answer this question.
Kind of expected question. Thank you very much for asking that question. Yes, so we adopt a lot of courses and we advise a lot of courses happening internationally, so we can connect you and advise you which courses are the best courses in every region and every country. And we do our courses as well in multiple countries in the Gulf and UK and Ireland. There's plenty of courses that you can attend physically to improve hands-on. For instance, we are doing a 4-day course starting from ultrasound, basic echo, advanced echo, and focused transesophageal echo as hands-on. But again, we are not limiting the fellowship to that at all. We are just advisor for these courses, so you can go and do that on your own. That's the first step to get some hands-on exposure. But you present the certificate to us, and then we will consider that in the last fellowship certificate we issue you. That's the first thing. In the term of virtual, this will be for all our candidates for advanced critical care sector or track or section versus the obstetrics and gynae, for instance, in the emergency. So we are doing that as like a virtual help. According to the logbook, yes, we will facilitate some mentorship and supervisorship remotely via different platforms that will facilitate your job. So it's been a struggle in the past 15, 20 years. Who can mentor me? Who can supervise me? Is it locally, remotely? So we are currently in the process of finding a way to do that. It is almost done, I can assure you. But again, this is just the first webinar. More details coming in the coming webinars. I promise you, if you follow us up, in the next webinars, you will get an answers crystal clear about everything you ask about. But we are not entitled to say that in this moment.
Thanks a lot. Thanks a lot, Walid. We come to the end of this first webinar. Personally, I really must congratulate all of you for organizing this. This is so useful. We have to teach many people today in the as you said, in the critical care world, and so such teaching programs are absolutely necessary. And so congratulations for this great initiative. I leave the microphone to you, Ashraf, for some ending remarks, please.
Yeah, it was great. Thank you very much for our moderators, Dr. Xavier Monnet and Dr. Haytham Khalifa, and for the speakers, Dr. Walid Alhabashy and Dr. Wesam Ibrahim. Please prepare yourself and join us, mark your agenda in the next webinar, which is going to be April 15. The next one to this will be May 13. And then we're going to end before we start the journey with our fellowship program. By June 10 will be the last live webinar before we start on June 30. Again, thank you very much for everybody. Thank you. A special thank to WICCEM, particularly Dr. Amr Al-Husseini, who's the president of this very nice institution. And of course, the great thank goes to ICOM as an organizing, very beautiful organizing company for our activities. Thank you again, and see you in the next webinar. Bye-bye.
Bye-bye.